We'll wait another minute or two for letting people in.
Sounds good.
Well, I think we'll go ahead and get started. Welcome to Pathology Grand Rounds at Brigham and Women's Hospital. We are pleased today to have at a distance Dr. Nasir Rajpoot, who's a leader in translational computational pathology and artificial intelligence as it applies to pathology. He is developing novel computational pathology and artificial intelligent algorithms with applications to computer-assisted grading of cancer and image-based markers for prediction of cancer progression and survival. He's the founding head of the Tissue Image Analytics Laboratory at the University of Warwick in the United Kingdom since 2012, where he leads a program of research on novel algorithms for analytics of digital images of human and mouse tissue. He's also professor of computational pathology at the University of Warwick and an honorary scientist in the Department of Pathology at University Hospitals Coventry and Warwickshire, which is part of the NHS Trust in Great Britain. He hails from the ancient city of Multan, which I believe is part of the modern day Pakistan. He completed his PhD in computer science from Warwick in 2001, and he was a postgraduate research fellow in the applied math program at Yale. He's been active in the digital pathology community for over a decade, and since 2015 has delivered over 50 invited and keynote talks at various national and international events and institutions. He recently served as the president of the European Congress on Digital Pathology last year. Professor Rajpoot was recently awarded the Wolfson Fellowship by the UK Royal Society and the Turing Fellowship by the Alan Turing Institute, which is the UK's National Data Science Institute. And his work has looked predominantly at colorectal cancer, and he's also done studies that have involved oral squamous cell carcinoma, ovarian cancer, lymphomas, and others. Professor Rajpoot, thank you so much for participating today.
Thank you for having me. Thank you for that kind introduction. It's a privilege and honor to be able to speak to this forum of pathology grand rounds at BWH. I'm a big fan of some of the work that's coming out of BWH previously from Andy Beck's group and now from Mahmoud Lab. So as you said, I'm a computer scientist. I got my PhD from the University of Warwick in 2001. And for about 15 years, just over 15 years, I've been looking at pathology images in one way or another. And I would like to talk to you about the past, the present, and the future of what has become known as computational pathology over the last few years. Really a discipline in its own right, sitting at the interface of medicine and computer science. I don't know if it's a branch of computer science or a branch of medicine or pathology, but in any case, computational pathology is becoming quite rightly a discipline in itself. And we're now looking towards the future in petascale computational pathology, and I'll talk a little bit about it towards the middle and then towards the end of my talk. So let's kick in. So starting off with the disclosures, I have a PhD student who is co-funded by Philips Healthcare. I also have another PhD student who is funded by Intel Health and Life Sciences via the Alan Turing Institute, and the Philips Healthcare are co-funding the PathLAKE Center of Excellence on AI in Pathology, which I'll talk about towards the end. I've also done some consultancy for Merck and have had funding from GE Healthcare in the past. I don't think I need to preach to the converted how the pathology practice works, but basically histopathology works in the following way. In most places in pathology labs across the world, a pathologist gets sent a whole bunch of tissue slides, looks at them under the microscope, where it looks a little bit like that, and they make a decision on what kind of tissue it might be, or for the entire case, whether it's diseased tissue or not, and if it's diseased, if it's cancer or not, and if it's cancer, how bad it is, or what particular subtype of cancer it might be, and so on. And obviously, that is extremely important from the point of view of deciding on treatment for the patient, because no diagnosis, no treatment, and histopathology remains the gold standard for most solid tissue tumors for diagnostic purposes. What a pathologist is kind of doing under the microscope is they are examining these battered relics of the past. As an English polymath who invented the blueprint, John Herschel, said, "Words are to the anthropologist what rolled pebbles are to the geologist. They are battered relics of the past ages, often containing within them indelible records capable of intelligent interpretation." And as Siddharth Mukherjee in his book, The Emperor of All Maladies, says, this was an illuminating insight that a scientist could understand the present and predict the future, perhaps, by examining those battered relics of the past. And the key word here is examining, and most of this examination takes place visually when a pathologist is looking down the microscope, and there isn't much of a computer intervention or algorithmic data that the pathologist is presented with. And a lot of times they are relying on their expert judgment. So let's talk a little bit about the expert judgment and the pitfalls of expert judgment. There's a really nice book by the name of Clinical versus Statistical Prediction by Paul Meehl, who was a statistical scientist, social scientist. And what he showed was, he looked at 20 studies comparing clinical predictions of trained professionals, including pathologists, based on their subjective impressions, such as visual examination, with statistical predictions that combined a few scores or ratings. Turns out now that study has been expanded to over 200 studies. But at that time, when the book was published, he showed that about 60% of those 20 studies showed significantly better accuracy for the algorithms as compared to the clinical predictions. And that's really a humbling indictment, because what it shows is that experts are really good at what they're doing, but they're also not necessarily consistent all the time. And that's really a key problem with subjective impressions and visual examinations, that invariably and inevitably, we are going to be inconsistent between ourselves and within ourselves. So what can we do here? Well, first of all, we need to overcome the problem of inconsistency, because inconsistency could be destructive for any predictive validity, according to Daniel Kahneman, the author of the bestseller Thinking Fast and Slow. And I think primarily, as Daniel Kahneman puts it, it's because pathologists and many other trained professionals, clinicians, are working in low validity environments, which involve a significant degree of uncertainty and unpredictability. So what can we do? Well, if we go back about 150 years, this is German physiologist called Werort, who is credited with performing the first blood count. And his technique that was published in 1852 involved aspirating a carefully measured volume of blood into a capillary tube and spreading it onto a microscope slide coated with egg white. And after the blood dried, he counted every single cell on the slide. And this process could take up to 3 hours to complete. But I think this is quite a remarkable moment in time for pathology, because it initiated the quantitative analysis that is, really fundamental to making the process of diagnosis all that more objective and a bit more consistent than it might be otherwise if we are only relying on subjective analysis and visual examination. However, what it also means is that it could be somewhat inconvenient just looking down the microscope, going over the entire slide and counting every individual cell that you see would be somewhat inconvenient and time consuming. And that's why we now have image-based cytometry and flow cytometry as routine practice. Now, this all is relevant to the work of Sidney Farber, whom some of you may be associated with the Dana-Farber Institute, it's, I know, just down the road. He was a world-renowned pediatric pathologist, acknowledged quite rightly as the father of modern chemotherapy. And he recognized that folic acid stimulated leukemic cell growth and enhanced disease progression. And he hypothesized that folic acid antagonists would inhibit or arrest the proliferation of cancer cells. And the rest is really history. He was the first one to show that these kind of somewhat cytotoxic drugs could be used for treating leukemia in kids. And one of the things that he presented in this seminal paper in 1948 was 5 cases of different kids that he treated at different times and showed varying degree of remission. And until that time, it was really difficult to treat pediatric leukemias. And one of the things that he was doing over and over again was counting the number of white blood cells in each of the cases before treatment and after treatment. And that is quite fundamental to any kind of analysis that we do in science. And again, going back to Siddharth Mukherjee, he reminds us that science begins with counting, that to understand a phenomenon, scientists must describe it objectively. And if cancer medicine was to be transformed into a rigorous science, then cancer would need to be counted somehow, measured in some reliable, reproducible way. And he was talking of Sidney Farber's approach to treating childhood leukemia in his book. Now, again, I would like to emphasize here that these are the things that are really fundamental to analyzing these tissue specimens under the microscope. And as of now, we don't really have in practice any rigorous, robust methods for doing the kind of things that we can now do in blood, and we do routinely, counting different number of cells, for example. So I think to make the whole process a bit more objective, reproducible, and reliable, we do need to go towards that direction. Now, before I talk about petascale computational pathology, allow me to talk a little bit about kiloscale computational pathology, because I think, again, it's important that we have some view of the past. As Robert Heinlein said, a generation which ignores history has no past and no future. Now, there's a million times difference between the kiloscale and the petascale. That's order of 12 orders of magnitude difference. However, when you look at this paper that was published about 55 years ago, it's quite extraordinary that Judith Prewitt, who is also quite popular in the image analysis domain, she was one of the scientists who came up with one of the first edge detectors in image analysis. And back in 1965, she was talking about in this abstract that the automation of the acquisition interpretation of data in microscopy had been a focus of biomedical research for almost a decade, and that mechanical perception of microscopic fields with a reliability that would inspire routine application still eluded us. So who knows, maybe 55 years later, we'll still be eluded by what we are able to do. However, Having said that, I think there are some significant developments of late that give us a bit more promise into the future. But let's just look at just very quickly for a couple of minutes, the kind of things that she was looking at. She was developing computer algorithms for recognizing the different type of cells, such as the lymphocytes, the eosinophils, the neutrophils, and the monocytes. And she was looking at the optical density, which is a measure of absorbance of light. You can define it as the ratio of the intensity of light falling upon a material and the intensity transmitted. And she found that there was a difference in the absorbance of light for the various different types of cells. She then started looking at various different combinations of optical density with nuclear area and the cytoplasmic area. And eventually she found, so here she's analyzing nuclear area versus cytoplasmic area versus the OD contrast. Finally, she found that using the cytoplasmic area, the nuclear cytoplasmic contrast, and the nuclear area, one could separate these 4 different types of cells. And I think, again, that's quite extraordinary that in those days and that age, she was able to separate out these different types of cells using basic measurements, even though there were no digital cameras and there were no GPUs as we have now at our disposal. She was also looking at cell graphs, analyzing the spatial connections between different types of cells. This is a paper published in 1979. And in here, she constructed a cell graph of the cat muscle tissue stained with ATPase, showing 3 different fiber types that are denoted by circles, triangles, and squares here. And then she was also looking at the various different kinds of edges between the different kinds of fibers. And this graph, she even mentioned that it could be interpreted as a network to encode cellular communication pathways, which I think is quite extraordinary. She's a person who was far ahead of her time. And now we have people looking at similar kind of social networks. Our group has done that in the past. And I'll tell you a little bit about the implications of that on colorectal cancer. But it's quite amazing that even in kiloscale computational pathology times, there were some extraordinary developments, albeit not so widespread. However, now we are entering the era of digital pathology, and pathology has recently, in many places, including in our own local hospital in Coventry, has gone digital, meaning that you can now load up a tray of 100 slides and chuck them into the scanner, and several trays at the same time. And each of those slides gets picked up by a robot arm inside the scanner, gets scanned at pretty good resolution, up to 250 nanometers per pixel, to produce a digitized image. Now, that's really great news for us because it produces lots and lots of raw pixel data, which could be crunched and could be used for the purposes of putting up some numbers in front of the pathologist, the kind of numbers that would be really useful to making the whole process objective, reproducible, and reliable. And back in 2016, so this was a study that was completed in 2015 and then published in 2016 in Histopathology, still remains the world's largest validation study of digital pathology imaging for primary histopathology diagnosis. We had 17 pathologists who re-reported more than 3,000 cases by digital and looked at the same cases at the light microscopy as well. And of these, just over 1,000 were re-reported by the same pathologist, and just over 2,000 were reported by a different pathologist. This involved 10 different subspecialties and more than 11,000 slides. And it showed that digital pathology was non-inferior to light microscopy for diagnostic purposes, which is great news, meaning that we could then push ahead with the routine diagnosis based on digital, and that's what's been happening in our local hospital down the road for the last many years. So what does that mean? For every image, we have billions of pixels. So that means huge amounts of raw image data. That's great news to start with. However, huge amount of data does not necessarily mean equally large amount of knowledge. To extract useful knowledge from all that raw pixel data, we do need to go through algorithms that learn from manual annotations, for example, to try and recognize different types of primitives, different types of cells, for example, different types of regions, and build models that could be hopefully interpreted and finally be incorporated into computer-assisted diagnostic systems or for computerized precision medicine in the long run. So we're in the business of taking these raw numbers and crunching them in this pyramid to extract knowledge that is kind of summarizing all the patterns that we are seeing across large cohorts of patients for various different types of cancers. Okay, so once again, why we're calling it Petascale Computational Pathology, because now we are entering where medium hospitals even that have been digitized for a little while, or research labs that have had scanners for a little while, are already sitting on digitized whole slide images for tens of thousands, potentially hundreds of thousands, millions of slides already. And that's again great news, because in terms of raw pixel data, each of these slides could be could be representing about 90 gigabytes of data. And just to put things into perspective, as compared to chest x-rays, that's about 85,000 chest x-rays in a single image, in a single slide. And obviously for a case, we could have dozens, or even in case of template biopsies of prostate, hundreds of slides. So if you go up to 12,000 slides, you're already reaching a petabyte for raw pixel data. And routinely, we are now seeing papers that are dealing with that kind of volume of data, including our own group. We're now looking at those kind of volumes. What that means is that we now have an opportunity for AI algorithms to make really serious interventions for early diagnosis and personalized treatment, because of this huge amount of pixel data that can feed into data-hungry algorithms like deep learning. And also we have now at our disposal, a lot of places, GPU compute infrastructure that is much cheaper than it was literally only 5 years ago. And that is an opportunity for targeted medicine. Now, in terms of the hype for digital pathology, this is where I think we are. There is quite a lot of activity beyond the early adopters. We consider ourselves, our local hospital, as the early adopter. So a lot of activity now in the UK in particular. There's a major push for digitization of pathology labs, histopathology labs. Recently, we've had a couple of national centers of excellence on AI in pathology funded, and one of the major objectives there is to digitize increasing number of hospitals. However, on this hype cycle, what we can also see is that usually there's a trough of disillusionment before we get back on the slope of enlightenment. So really what we're looking for is a bridging of this gap as much as possible, so that we don't go through this trough of disillusionment for too much longer. In terms of computational pathology, I think we are a little bit behind. Obviously, computational pathology requires the data that has been generated. Now I'm talking about the clinical space. The pharma space is probably much further ahead, because obviously their scanners have been in operation for quite some time, and lots of data has already been collected. But in the clinical space, I think this is where we are. We are still having some early adopters that are investigating the use of AI in pathology labs. And there is a bit of mass media hype that is going on as well. But hopefully there is enough promise and enough evidence that will be generated in the next few years, really in the near term, or the next couple of years. I'm quite confident about that, that we'll be moving on to the rest of the hype cycle fairly soon, hopefully bypassing this big dip that usually happens with a lot of the new technologies and getting onto the slope of enlightenment fairly soon. Okay, so with that introduction, I would like to move on to the second part of the talk, where I will tell you a little bit about the algorithms, some of the algorithms that we have been developing in my lab, some very basic type of algorithms, and then moving on to personalized treatment and some algorithms that could be used for risk stratification of patients in the context of tumor microenvironment. And then towards the second half of the talk, or towards the sort of last third of my talk, I'll talk about Petascale Computational Pathology challenges that are specific to Petascale Computational Pathology, and talk a little bit about the PathLAKE Center of Excellence towards the end as well. Okay, so in my lab over the last decade or so, we've been developing a whole raft of algorithms, starting from pre-processing to analysis and modeling and recognition of different types of objects, to virtual tumor microenvironment markers, and finally putting it all into fruition to be able to predict survival, risk stratification, predict response to therapy, and so on. So just very quickly, one of the algorithms for normalization of stain, which was a major problem, probably not so much of a major problem anymore, but nevertheless, we do want as much of normalization of the data, standardization of the data as possible. And this problem is really to deal with the problem of stain variation that is inevitable in most pathology labs due to various reasons. The time of the day that the stain is being applied, or the person who is doing the staining, the supplier of the stain, the temperature of the room, and so on. So back in 2014, we published this paper on normalization of stains together with colleagues at Leeds University. And without going into the mathematical details, knowing the audience being mostly from a pathology background, the idea here is to extract the channel statistics for each of the hematoxin, eosin, and background channels for both source and target images, and then map the channel statistics of the source image into the channel statistics of the target image to construct normalized stain channels, and eventually to construct the normalized source image. And the result of that was quite nice, that we started off with these images with all kinds of hues and colors of hematoxin and eosin, and ended up with more or less similar looking colors for all those different images. Okay, so that's pre-processing, just one type of pre-processing problem, just talking about some recognition and modeling problems. Really important to be able to recognize the different types of cells if you're working bottom up, something that I'll talk about a bit later on. So in this paper, we presented a novel method for recognizing different types of cells. And that, I think, if you're working bottom up, can be quite useful for digital profiling of the tumor microenvironment and for better understanding of the state of the battle that is going on in this histology landscape that I call the reality on the ground in terms of what's happening at any one given point in time in cancer within the patient's body. There is another algorithm which is currently the state of the art for segmentation of different types of nuclei and their classification, simultaneous classification. So it works on a whole variety of different types of cells, on malignant dysplastic epithelial cells, normal epithelial, fibroblast, inflammatory, muscle cells, endothelial cells, and the other type of cells. And here, Simon Graham, who just finished his PhD and joined us as a data scientist in the group, he performed an extensive comparison with a whole range of other algorithms, together with another PhD student, Dang Wu. And this was published towards the end of last year, Medical Image Analysis, for 3 different data sets, comparison with some of the state-of-the-art algorithms at that time, showed that it performed quite well. And we also released this data set consisting of over 24,000 nuclei with segmentation masks and class labels that people have been using quite a bit. Just another one of those primitive deep learning AI type of algorithms that we call NuClick, very recently accepted for publication in medical image analysis, still in press, but already available as early access on the medical image analysis webpage. The idea here is to try and minimize the annotation burden on the pathologist so they don't have to annotate every single cell every time you're analyzing a new type of tissue, because every tissue can have different types of cells. So they just click somewhere near the middle of the nucleus, and then the algorithm fills in the rest of the nucleus mask for the machine learning scientists. And this was used to put together a data set of 200,000 plus pan-cancer nuclei from TCGA. And the data set is publicly available. It's called the PanNuke dataset. And again, NuClick was used for collecting segmentation masks. So the pathologist would be using click, and then segmentation maps will be generated, verified by a pathologist, and then made publicly available. Here's another algorithm for gland segmentation from nuclei, different types of cells, to different types of regions that could be of interest from diagnostic and prognostic and perhaps even predictive viewpoints. So in this case, a new network that we call MileNet, neural network for segmentation of glands in colorectal histology images. And this actually works quite well on both benign and malignant glands, as you can see here in the normal mucosa and also in poorly differentiated region. This bigger type of vision that you could perhaps think of is the tumor, bulk of tumor in a given image. Usually the tumor areas contain tumor nuclei that are clumped together, that are filling the intercellular regions, and the structure of individual nuclei becomes more and more difficult to discern, whereas nuclei remain relatively distinct in normal regions and maintain their structure and appearance. So in this paper, we put together a concept by the name of persistent homology from mathematical topology and combined it with the science for cluster tumor segmentation. And the results were quite encouraging. And we showed on two different cohorts, one from the UK and one from Japan, that the combination works better than any of the methods on their own. Okay, so with that kind of a quick overview of some of the algorithms, I would like to move on to the next part of the talk, where I'll talk a little bit about precision medicine and personalized treatment. And we all know that precision medicine, personalized treatment, one of the goals is to try and minimize the toxicity and maximize the efficacy and response to the therapy for a given patient. So everyone knows about cytotoxicity. There is also the issue of financial toxicity, because all of these drugs cost quite a lot. So this is from the book Hope or Hype, the obsession with medical advances and the high cost of false promises. Just to put things in perspective, that we all need to be careful about all the hype that may be around technologies and around some of the new therapies, and work towards finding the right kind of technologies in the context of picking the right kind of therapy for a given patient. There was a very nice debate on the American Association of Cancer Research annual meeting in April 2018. And at the same time this paper came out, just on the day of that panel discussion, in the evening of that panel discussion, this paper came out in JAMA Oncology, and two of the debaters on that panel discussion were Vinay Prasad and David Hyman, where Vinay Prasad, last author of this paper, was trying to show that genomic medicine has perhaps been overpromised for some time and been overfunded for some time. These two graphs, the left and the right, they show on the left-hand side the estimation of the percentage of US patients who benefited, who were eligible for genome-driven treatments. And on the right-hand side, patients who actually benefited. And the numbers are really sobering. Only 8.3% of the total number of patients were eligible for genomically targeted drugs. And of those, there were about 50% that responded. So the total benefit to all the patients amounted to just under 5%. And one of the points that Dr. Prasad made in his speech at that just before that panel discussion was that things that we were hearing, and we still continue to hear, that we don't really need histology, just use mutations, and every individual patient is going to be eligible for one or more of the targeted drugs. And that we were already reaching a point of inflection in genomic-driven oncology. And the point he was trying to make also was that that could be, a bit of a hype, if I can just try to tone it down a little bit, that there was some benefit, but there was also a lot of hype around the effectiveness and the benefit to a larger population of cancer patients. And recently, last year, they did a similar kind of study for immune checkpoint inhibitors. And on the left-hand side, again, eligibility of patients to immune checkpoint inhibitors, various kinds of FDA-approved drugs. And again, they showed that the eligibility was less than 50%. But perhaps even more sobering is the number here on the right-hand side, which shows that the number of patients, the percent of patients that actually responded to these new immunotherapy type of drugs was under 15%. So I think there is a lot of work to be done. And again, I'll come back to the point that perhaps genomics is not the entire story. Perhaps we also need to combine it with the huge amount of pixel data that we now have at our disposal, and profile what I call the spatial tumor microenvironment, because we know that there are other important players other than the tumor cells in the microenvironment as well. And I don't need to preach to the choir. I'm sure most people here are familiar with the role of the tumor niche, the tumor budding, immune infiltrates, the vasculature, the cancer-associated fibroblasts in the development and progression of tumor. So I think there's an opportunity here for us to perhaps exploit these large amounts of pixel data that is being generated, has been generated in many cases, together with genomics and come up with better, stronger predictors of response to therapy, for example, and risk stratification. So a couple of examples from our own lab on that front. Here is one where we use cell-cell connection analytics, building a kind of social network of different types of cells, and then extracting some measurements from that social network, kind of a little fingerprint that could then be used to phenotype different type of tissue in an automated manner within the same slide, and extract some summary statistics, in this case, the ratio of inflammatory cells to the entire tissue, and use that statistic to stratify patients. These are all locally advanced stage 2 colorectal adenocarcinoma patients, and we're predicting this distant metastasis-free survival. So these are quite interesting preliminary results. We're now in the process of validating this to larger cohort. My next story is going to be about oral cancer. Just very quickly again, the global burden of cancer in the advanced world. So in blue, you're seeing the incidence, in red, mortality. And if we compare the statistics for the advanced world to the statistics of the less developed parts of the world, it's quite startling to see that the ratio of the incidence to mortality is quite high in the less developed parts of the world as compared to the developed world. And in a lot of cases, cancers are diagnosed late. A lot of cases, they're not treated, and the diagnosis of cancer, unfortunately, can be a bit like a death sentence. and in particular in South Asia, oral squamous cell carcinoma and oral cancer in general is really one of the top ones, in fact, the topmost one in both India and Pakistan. So we started looking at the tumor infiltrating lymphocytes and came up with the TIL abundance score, a digital measure of the abundance of TILs for predicting disease-free survival in oral cancer. And here you see the results of the deep learning algorithm for differentiating tumor and non-tumor regions or lymphocytic regions. And then constructing a kind of heat map of where the bulk of the tumor infiltrating lymphocytes might be, and from those come up with a single score of TIL abundance for the entire tissue specimen, and use that score for differentiating between high risk and low risk cases in oral squamous cell carcinoma. Again, these are preliminary results, and we're now in the process of in fact, we have done a large-scale validation of this, and more to come on this. Just very quickly, in diffuse large B-cell lymphoma, we have looked at collagen tumor proximity analytics. And collagen is, of course, an important component in the tumor microenvironment, in the stromal microenvironment. And its presence has been linked to outcome in urothelial and colorectal carcinomas, which meant that it warranted further investigation of its role in DLBCL. So just very quickly here, we were looking at COL6 in particular, a particular type of collagen. And what we did here was we put circle on the of the collagen fibers, and we counted the number of tumor cells, again, to give a kind of digital fingerprint of the state of the proximity between tumor and collagen fibers, and use that to stratify patients again into low risk and high risk for two separate cohorts, and showed good separation there. Okay, more recently, deep learning algorithms have been used for prediction of mutations and classification of non-small cell lung cancer histopathology images, in this case, in a Nature Medicine paper a couple of years ago, and have been shown to predict breast cancer grade, ER status, histological subtype. This is another paper from last year in Nature Medicine, where colleagues from a German group showed that deep learning could predict microsatellite instability directly from histology in GI cancer. And at the bottom, another group from Oxford, author, showed that you could consensus molecular subtypes in colorectal cancer using deep learning on histology images. Very recently, just a couple of months ago, towards the tail end of July, in Nature Cancer, the same issue, there were two papers, back-to-back papers on pan-cancer computational, showed that you could detect clinically actionable genetic, and another group from Cambridge that showed that you could predict mutations, tumor composition, copy number alterations, whole genome duplications, and a whole variety of clinical and genomic variables from histology images alone. However, when you look at some of these data in detail, you will find that, for instance, in terms of the actual AUROC area under the ROC curve, most of the numbers are below 0.8, some in the territory of 0.3, and anything above 0.5, the authors consider being significant. And pretty much the same story in the other paper as well, from the Cambridge group, where, for instance, when they were predicting whole genome duplications, they called anything with AUC of above 0.5 as predictive, which I think is quite remarkable, to say the least. And they only had 4 cancer types where they showed an AUC of greater than 0.8. For prediction of histopathological subtypes and grades, the AUC was 0.59. So I think, again, this is quite humbling and sobering when you look at these numbers. What it shows is there is some potential, for instance, in these cases, but also that there's a lot of work to be done to get more accurate predictions. We don't just want to make things objective, overcome the problems of subjectivity, but also we want to make things more accurate and reliable. So some of our own work, recently unpublished work, we used exactly the same cohort that was used, the TCGA cohort in the Nature Medicine paper by Jacob Cather et al. We showed that we get better AUC. And I think anything above 0.8 is certainly something that could be considered seriously. And we actually looked at not just MSI, but also SYN and SIMP pathways. So these are the three core molecular pathways, MSI, SYN, and SIMP in case of colorectal cancer. But also we showed that you could predict BRAF with relatively decent accuracy. We dug deeper into the areas of the image, the whole slide images that were showing MSI positivity, MSI highness, and MSI lowness, so to speak. And again, in the interest of time, I'll skip over details, but just to say that TILs and necrotic debris were found to be quite often key morphological features of regions that were MSI high. And we also looked at correlations between digital MSI scores and the digital SIMP scores, good positive correlation, digital MSI score and digital SYN score, good negative correlation, which is also in line with what's known out there, and between MSI and BRAF, strong positive correlation as well. All right. So just to summarize in the interest of time, I'm just going to talk very quickly about three major challenges that the petascale computational pathology is facing. I think there is a kind of chasm between end-to-end machine learning versus bottom-up learning. End-to-end machine learning being, let's put all the image data into a large convolutional neural network and get some kind of prediction out of the network and train that with lots and lots of data, versus bottom-up approach, which has been our approach up until recently, that we learn some of these primitives, recognize them, and then build summary stats from those primitives so that we can build features that could be clinically translatable and meaningful. There's also another approach that is kind of forming another paradigm, which is the top-down approach, that you do analysis of the entire image and then pick out areas like the hotspots I showed you for MSI, and then analyze those further. So there's probably that third approach in there as well. Visual context and attention is all the more important because we're dealing with large images here and figuring out where to pay attention to. And there's some really nice work coming out of Dr. Mahmood's lab in that space. And context obviously also really important because a lot of people chopping up these images into small pieces and analyzing each of those pieces separately as if they existed completely independently. And I think that's a mistake because none of these patches are existing independently. And then finally, do we bring data to compute, or do we bring compute to the data? And I think there is a debate to be had there as well. And my feeling is that in a lot of cases, you're probably better off to bring the data to the compute rather than, compute to the data rather than bringing the data to the compute, because it's a huge amount of data that we are talking about. So I'll jump to PathLAKE, which is our center of excellence that has been funded recently, that I'm co-directing, where our model is that we're bringing in data from the National Health Services pathology labs, putting them in the central data lake together with our analytics engine so that third-party researchers and industry, they could gain access to the data and conduct their analytics within the data lake without having to download the data and without having huge computational resources at their disposal. And finally, just to say that what we are trying to do here is to put the objective measures of the tumor microenvironment in front of the pathologists so that they can hopefully get a better handle on the state of the battle that is cancer, together with deep learning and analytics algorithms, we could do better job of predictive analytics and risk scoring for progression, and integrated diagnostics with the genomics data. And finally, will AI replace pathologists? Well, my view there is the same as Darwin's view, that it's not the strongest of the species that survives, not the most intelligent. It's the one that is the most adoptable change, and the change is coming. And my view is that pathologists who adopt the change will survive more likely than the ones who don't. And finally, thank you very much. And thanks to all the funders, all the collaborators, and most importantly, all the students and postdocs that made all this work happen.
Thank you very much. I wonder if I might start the discussion by asking you to give us a high-level approach to taking this kind of information to standard of care. What would be the pathway in terms of regulatory and other constraints?
Yeah, I actually had a slide on that, which I skipped, but let me see if I can put it up. We recently published—
I encourage others to ask questions following in the chat or by unmuting.
So for routine clinical practice, I think first and foremost, of course, we need to ensure that labs are digitized. If there is no digital scanners, none of this fancy stuff can happen. But once digitization has taken place, we're now in the process of putting together well-curated data repositories that are annotated appropriately by the right kind of people to drive the AI innovation, so that we could go through the validation procedures and regulatory approvals and enable the commercialization of those products for clinical adoption. There's also, so I didn't have time to go through this, there's also this paper that we jointly published with colleagues from Oxford, who are also part of the PathLAKE project, as a roadmap for clinical adoption of AI in pathology. It starts from a developer, an AI scientist, a machine learning scientist having an idea, going through ethical approval, building pilot algorithm, demonstrating proof of concept. And this is a slightly longer way, whereas this is a slightly shorter way: in-house validation verification, and then LDT, accreditation, diagnostic use, and incorporation into management guidelines, such as NICE guidelines in the UK. I hope that answers your question.
Thank you very much. I welcome others unmuting or asking questions in the chat of Dr. Rajpoot.
Hi, Dr. Rajpoot. My name is Drew. I'm a third-year AP resident doing some computational pathology with Dr. Mahmood. I'm just wondering, for like full-scale clinical adoption, do you think we're still lagging behind in the hardware department? Do we need new advances in hardware to sort of have the radiology experience in pathology?
That's an excellent question. Depends what you want to do. If you're after imaging the entire tissue block, cutting loads of sections and scanning each of those sections, then yes, we're not there yet. If you're after staining the tissue with multiple markers and scanning them at the same time, then we're not there yet. However, I think with the standard IHC and H&E, the scanners that we have now, some of them can do scanning in just over a minute per slide. So if you have a busy lab, 1,000 slides, let's say, per day is quite normal for a medium-sized lab. But if you have a larger volume, then obviously you need more scanners. But I think most of us are pretty happy with the quality of images that are generated by many of the scanners, certainly the volume, the throughput of the scanners is probably sufficient to go to go digital for most of the labs. That's my view, at least. Do you see any other challenges there?
I guess for the machine learning side, do we need to be able to fit multiple whole slide images in like GPU memory before we can have like fully performant pathology?
Yeah, absolutely. That's again a very good question, and I didn't have time to go through some of the stuff. Obviously, there's only so much that I can talk about, but perhaps one of the things that I can mention here is this idea of graphs that we have recently been looking at. As you said, I don't think there's any GPU out there that can take the entire digital slide. So what normally happens is that people chop up images into small patches and try to recognize different kinds of things in each of those patches. That can help. However, so I think this is the slide I was looking for. So this is our recent paper that was presented just a few months back at the CVPR workshop on graphs, where what we do is we take a whole slide image, recognize different types of nuclei, and classify them, and then do a bit of spatial clustering, construct a graph, chuck that graph into a graph convolution neural network, and then from that, you can put an entire graph of an image into a small graph convolution neural network to get quite decent accuracy in scale and R status in a breast cancer cohort. So that's one way of going about it. This probably doesn't answer your question completely, because I think there are methods developments that that we need to work on to make sure that we are capturing the entirety of the tissue architecture that individual patches do not necessarily capture, but also on the GPU front, perhaps larger memories, so that we can do more of the slide raw pixel data, chuck it straight into the GPU.
Jeff.
Thank you.
Thank you, Dr. Rajpoot. That was really interesting. I wonder if you've thought much about the way, particularly pathology data, is structured and what that means for democratizing or using these algorithms more broadly. I mean, one of the advantages of radiology was when they used DICOM, and there are some efforts to create a DICOM standard for pathology, but how do you digest your data in a way that could be used by many different systems rather than just by how you've set it up?
That's an excellent question again. Thank you for that. So our mantra is that we want to put together data in the repository, the PathLAKE repository, that is following the FAIR principles, that we make use of the open source libraries and the open image formats as much as possible, and that the data sitting in the data lake follow the FAIR principles, i.e. it's findable, accessible, and interoperable, which is probably what you're referring to in your question, and reusable. So interoperability is a challenge in pathology at the moment, and there isn't a DICOM there. In the UK, we have the LEADS consortium that is working on the kind of acceleration of the DICOM standard for pathology images. But in our network in PathLAKE, our focus is really more on open source formats for machine learning purposes. And for that, we are pretty happy with the Pyramid TIFF at the moment, but we are also looking at some of the next generation file formats for data that is going to be residing in the data lake. Does that answer your question?
Yeah, it does. I mean, from my standpoint, that's what you're describing works fantastic for the innovation, the development of the algorithms. The problem becomes the deployment, where these different systems have locked down their data with in a HIPAA compliant manner that requires us to have our data structured certain ways, and there's not a common way to do it. Thus, to deploy that algorithm once you've developed it, which I understand in a data lake, you can do that really well. We can't do that as easily with our data here. And so that's one of the challenges to getting to the delivery at the patient bedside, so to speak.
Yeah, absolutely. And as I said, DICOM does need a bit of work before we can get there. And that work is going on. It's really not in our remit to, we're very much supportive of the DICOM, DICOMization, if I may call it, of pathology images. But we're not directly involved in that effort. As I said, in the UK, LEADS consortium. So there were two main consortia that were funded last year by the UK government on AI in pathology. One is ours, the PathLAKE consortium, and the other one is the NPIC consortium led by colleagues at LEADS. And the other ones were looking at DICOMization.
Thank you.
We can take one more question, I think, if someone has one. Well, not hearing any. Dr. Rajpoot, thank you so much. And we look forward to hosting you at some point when the travel will be possible. Thank you.
Love to visit you. Thank you for having me.
Thanks a lot.
Bye-bye.